Natalie Holmes. I'm one of the orthopedic registrars at East Kent Hospitals University Foundation Trust within the UK. Sorry I can't be with you, but I'd like to talk to you about our study which looks at the survivorship and intermediate to long-term clinical and radiological results following the reverse shoulder arthroplasty with a stemless metaphyseal prosthesis. The incidence of shoulder arthroplasty is increasing, and as such, so is the volume of revision surgery. The indications for revision surgery include loosening of the glenoid component, any instability, periprosthetic fractures, component dissociation, infections, as well as failure of the anatomical arthroplasty. A diaphyseal humeral component contributes to the difficulties faced when there is revision surgery that is needed, as this has to be removed in full to allow for any issues such as bone loss and cortical thinning to be addressed within the surgery. With a diaphyseal humeral component, there is an increased risk of intraoperative periprosthetic fractures. So any revision surgery would then be simpler if the humeral bone stock is preserved. A short stem prosthesis providing stable fixation but preserving this humeral head has been developed and is increasingly researched for the use in reverse shoulder arthroplasties. This project aimed to present the medium to long-term clinical and radiological outcomes as well as the complications and survival rates for a stemless reverse shoulder arthroplasty prosthesis. Excuse me. So our methods, it was a single centre observational study and it included all patients that were undergoing primary or revision cementless reverse shoulder arthroplasty using this Verso press fit prosthesis. The study was approved by the local ethics committee and patients underwent a minimum of 5-year follow-up were then deemed eligible for the project. This looked at patients between November 2009 and December 2014, whereby 21 patients but 22 shoulders underwent this shoulder arthroplasty. It was prospectively collected, and one patient did pass away due to medical conditions before the 5-year follow-up, and therefore they were excluded. A further 3 patients unfortunately passed away due to other medical conditions, but they had completed their 5 years and so therefore they were included in the project. So the commonest approach used was the anterior superior or the Navasia-McKenzie approach. One case did have to undergo the delta pectoral approach due to anterior lock dislocation. A cutting guide of around 155 degrees to the anatomical axis was used to reset around 22 millimeters from the humeral head. Cancella's graft was harvested from this humeral head for impaction grafting into the metaphyseal to allow for a press fit fixation. This short stem design, the Verso prosthesis, consists of a short humeral component, as you see in the picture, with 3 hydroxyapatite coated tapered fins to allow biological fixation into the metaphysis, which is then further augmented by impaction bone grafting. The glenoid component is also a base plate with a central tapered hydroxyapatite coated porous screw. And there is the additional option for 2 derotational screws, which is recommended by the manufacturer for biomechanical rotational stability. The glenoid head is available in various sizes, including around a 36 and a 41. The polyethylene liner is inclined by about 10 degrees, wedged inframedially to reduce medial impingement. So when we looked at the indications for surgery for our patients, what we found was that the commonest reason for reverse shoulder arthroplasty was rotator cuff arthropathy, and this was seen in around 13 patients, and rheumatoid arthritis seen in around 3 patients. 2 patients underwent revision for failed shoulder resurfacing, and 3 patients underwent surgery because of trauma sequelae. So the results of our study showed there was a mean age of around 76 years, and the mean follow-up was around 78 months. Preoperative evaluation, both clinical and radiological, was recorded, and we used things like the Oxford Shoulder Score, the Constant-Murley Score, and the Adlia Score to report the patient's function. And what we found was that post-operatively all our patients did show an improved functional outcome. And the range of movement was determined using a geonometer by an independent observer. Radiographs were also assessed pre and post-operatively to determine the extent of arthritis. There were no radiolucencies noted around the glenoid component of any of our patients within this study. And when you look at the clinical scores, pre and post-operatively, what it showed was that our results were statistically significant in all 3 scoring systems, the Constant-Murley, the Oxford, and the Adlia score. When we looked at the radiological images, this required an AP and an axial view of the shoulder for all patients. These were reviewed by 2 independent shoulder surgeons to assess for loosening, osteolysis, any form of migration, notching, and any subsequent fractures. There was a standard template that was used to document if any of these signs were seen. And as I said before, our study showed that there were no radiolucencies post-operatively around the glenoid component. There were some radiolucencies around the humeral components in 2 patients, but no migration. And glenoid notching had a rate of around 23%. Complications. So what we had in our study was that 2 patients did have a periprosthetic fracture, but this was following trauma, and both of these were treated conservatively with the use of a sling. There was 1 case of an infection which required surgical washout and liner exchange, and 1 patient was found to have subsidence of the prosthesis during follow-up, but by about 3 years what they noted was that the varus tilting had stabilised and the clinical function was not actually affected. This patient had actually had her surgery because of failed Copeland's prosthesis. So if we look at some cases, so this is case 1 of a 75-year-old female with glenohumeral osteoarthritis, and the images show her pre and post-operative films, and this was actually 9 years post-surgery. Case 2 is the case of a patient who underwent reverse shoulder arthroplasty and sustained a periprosthetic fracture secondary to a mechanical fall. And as I said, this was treated with a sling, treated conservatively in a sling for 3 weeks, and this shows the subsequent healing of that fracture. Case 3 again is a case of a periprosthetic fracture, but this was in a 101-year-old with medical comorbidities, including at the time urosepsis and a transient ischemic attack. Hence the reason the need to treat conservatively in this case. So case 4 shows the use of the reverse shoulder arthroplasty as a result of a proximal humerus fracture when there is already a plate fixation for a diaphyseal humerus fracture. This table shows our study in comparison to other studies that are out there. What it shows is that our rate of complications in our study is comparable or better than reported in other studies. Our mean follow-up is much higher than even the Levi et al. Study, which had a 50-month follow-up. Ours is 78 average follow-up. The rate of scapular notching does vary. It can be as high as 88%, but actually on average we found it to be between 35 and 50%. Our rate within our study was around 23.5%. We had no radiolucence areas in the glenoid component and 2 periprosthetic fractures, but overall our study is comparable to other studies and actually does show some better sides. So the stemless reverse shoulder arthroplasty, it does preserve bone, so therefore makes any revision surgery easier. It means that periprosthetic fractures mainly occur within the metaphyseal region. We know, or we believe, that the metaphysis is directly loaded with this prosthesis by hoop stresses, and therefore preventing stress shielding because there's no stem to transmit the stress distally. The impaction bone grafting that is done intraoperatively as well may aid in this process, but it allows for periprosthetic fractures to be conserved in a sling versus major revision or ORIF, which, as we know, can be complex surgery. As I said, no radiological stress shielding because of the metaphyseal loading of this prosthesis. Radiological osteopenia was not a contraindication, and we, as I said, used the impaction bone grafting. So our study showed overall excellent clinical and radiological outcomes, and it's in this medium to long-term outcomes. This study has the longest mean follow-up. It reports very good patient satisfaction, and it combines the mechanical advantage of bone preservation with the metaphyseal loading to offer a very good option for elective reverse shoulder arthroplasty. These are the references that we used. We had no conflict of interest to report.